which is great. We'll just give it another minute. We'll start the recording. Thank you, Nathan. Okay, I think we've probably got most people back from their break, or they'll just be rejoining us shortly. So we will crack on. So we are on item number 5 of our agenda. So this is our finance assurance report, and this is the month 4 position. So Heleth, I will invite you to talk to this paper, please.
Thank you, Sarah. So at the end of July, we're reporting a deficit of 31.5 million. And due to an additional allocation that we've received, we have a slightly reduced forecast of 49.7 million. But that is still assuming full delivery of our cost reductions around value and efficiency, the break-even positions for both Argyll and Bute IJB and the adult social care position. Scottish Government are requesting that we improve our deficit position by the end of the financial year, and they are reiterating that the brokerage cap still stays at 28.4 million, which we're a significant distance from. As you can see in the paper, we are behind on our delivery of the value and efficiency programme. This is in part due to difficulties in estimating the financial impact of some of the actions taken. So as we go through the year, we'll hopefully realise those and have a clearer forecast of the savings that we'll be making, but also partly due to operational pressures that are making reducing some of our cost base more challenging. Would like to just highlight the adult social care position. So we have now progressed the quantum discussion with the Highland Council, and we do have an agreed quantum. We're just awaiting the final letter setting out that we have a draft version of that, and it does confirm the reduction of the 7 million. Council colleagues are committed to ensure that we do deliver a balanced position this year, but they do want us to focus on the use of the 20 million that's available to us for transformation, and that we can use that to develop a future care model that hopefully delivers care that we want it to deliver, but it's a reduced cost base to make it more sustainable going forward. So they really want us to focus on our areas of change and the utilisation of that funding. As Alec mentioned, the intention is to do a detailed forecast at the end of Q2. And at that time, we'll be considering the risk of delivering all of these elements, and we'll need to take a view as to whether we need to reset our forecast for the end of the year. Our biggest risk to delivery continue to be our reliance on supplementary staffing, the increased cost and use of medicines, and general inflationary pressures, which also reflect the areas that we are struggling to deliver on within the cost reduction plans as well, which are around the prescribing and supplementary staffing reductions. We're proactively engaging in all Scottish Government programmes to reduce our costs, and we are putting cost control measures in place where appropriate. So that's probably in summary the financial position. For the revenue side, from capital, as Alec again mentioned, the capital is being very tightly monitored due to the constraints. The allocation is fully committed, apart from a small contingency being held back, and we are getting assurance from the services that spend is in place. It's just not filtering through at the month 4 report. And we are providing clear reports to Scottish Government around backlog maintenance, our requirements, and we have had confirmation of some additional funding for Belford works, but that's not coming through in our allocation as yet. So we are presenting the report at limited assurance at the moment, just due to the delivery of the efficiency and value schemes and our uncertainty around the delivery of our current forecast, let alone the brokerage position. I'm happy to take any questions on the detail of the paper.
Thanks, Heleth. And obviously we get the opportunity to go through this in a much more granular level of detail when we go through FRP committee, but I'm happy to open up questions, comments. I'll open it up to the floor. Okay, Alex first, please.
So just confirmation, Helen, did you say that we've not yet had the letter, but we're accepting the 7 million quantum reduction in ASC funding?
We've not accepted anything. We've not formally had the letter. We've received a paper copy of the draft version last night, and so we're just waiting that final version to come through. But the council's really keen to work with us around how we use the 20 million funding that they're making available. They're really keen to focus on that and changing our model of care going forward and reducing our cost base so that we can make it sustainable. But they're also very keen that we're not in a position where, you know, health is left at financial detriment at the end of year either. So we need to work together to see how we can develop plans to progress that. But the conversation was very positive.
Good, thank you.
Good to hear. Thanks, Heleth. Karen, I'll bring you in next, please.
Thank you, Sarah, and thank you, Heleth. Just a question around the prescribing and hospital drugs cost. Interesting that there's an underspend in hospital and an overspend in prescribing, and I just wondered if we had more information around that. Is it in relation to supply chain, just number of drugs that are being prescribed, all of that kind of thing that we would expect, or is there any other factors in there that may be of interest for us to know a bit more around?
Prescribing is a really interesting one. So we do make assumptions at the beginning of the year around where we expect growth and the cost of drugs, etc., to be. Our costs are increasing across the board, but within primary care in particular, the utilisation, so our number of prescriptions and the unit cost of prescriptions are going up across the board. We are trying to put closer control measures in place around the acute drugs, because that's an area obviously where we've got more control. And Boyd will be able to talk to this probably much better than I can. And it's in the acute side that we are seeing those savings coming through because we have got more control again over switches. We're trying to have that conversation with primary care colleagues. We are having the conversation with primary care colleagues around switches that they need to make, but they have to balance the time that it takes to do that and the patient care alongside the switches. So it's a conversation that is progressing.
Thanks, Heleth. I don't know, Boyd, did you want to add in on that?
Thanks, Chair. Heleth has covered it very well. The aim of prescribing drug costs are a large part of costs for every health board. Cost of drugs and the amount of prescribing is continually going up. And so the main efforts are in maximising the efficiency, but ensuring that what is prescribed is appropriate, is cost effective, but also clinically effective. So there's quite a balance there. It's also lots of new drugs coming in the market that inevitably cost more because when they're new, they do. And the primary care spend in recent years has been affected in part by sort of access to the products that the manufacturers make. And that's a UK-wide problem, and I guess that if many drug companies are Europe-based, then naturally you could work out that the economics of that changed, and also some drugs are very cheap, and when they become very cheap, many manufacturers stop making them because there's limited profit. And then suddenly nobody's making them, and then somebody starts to make it, but puts the price up greatly. So there's a lot of variation in the market. And although this is, the NHS is a government-funded organisation, we are subject to market economics to some extent. What we do locally is mainly about cost containment, but ensuring quality prescribing as well. And even this morning, there have been prescribing efficiency meetings to continue the work that's needed on an ongoing basis to manage an ever-changing prescribing landscape.
Thank you, Boyd. Alistair, I'll bring you in next, please.
Yes, thank you. Well, the question I've got surrounds the reduction to the quantum and the 20 million transformation monies available. What is the process and the sign-off and the evidence that has to be produced in order to access the 20 million transformation part? Because my understanding is it's not just to balance a budget, it's got to have a specific purpose. And should we be accepting the 7 million reduction if we don't know what the process, sign-off and governance is around the 20 million, how to access the 20 million pot? Thank you.
Thank you, Alistair. There is a process in place. So any request for the 20 million at the moment comes through a kind of mini business case. So a case is put forward. We need to assess that internally to make sure that it's what we support and we think should happen. And then there is a meeting that's been set up by the council that both council and NHS attend, that then reviews and considers and agrees or not those bids. So that's the process. Given we haven't had the formal letter from the council yet, we haven't taken that decision as to how we respond back. What we don't want to do is get into a process where we're just to and fro in letters. So we've committed now to having bi-weekly or weekly meetings with the council around the financial position. And as I said, Fiona and I met with Derek and Brian last night with that commitment of making sure that we keep a really close eye on it and we work through that through conversation rather than through letter writing, which isn't the best use of anyone's time or progress, really. So there is a process for accessing the money. The council are also really clear that they could just hand it over and put it on our books if that would be easier, but it's not for us, because if we take it in its entirety, we will struggle with that mechanism of carrying it forward. So we also need to be really mindful of the best way to deal with money between organisations and where we would get best benefit from that. And at the moment, the best benefit of the 20 million is sat with the council until we've got plans to access it. So the 7 million, I think, is a further conversation that we need to have.
And I can see that Fiona's got her hand up, so I'll bring you in as well, Fiona, please.
Yes, thank you. I suppose I just wanted to add, having participated from that conversation last night, but with a non-technical answer, is that the focus of that money that the council want is around transformation and change. And as Helen said, we do have that mechanism, but one of the challenges we're experiencing, and our counterparts in the council are very sympathetic to this, is that the staff that we have who would be leading the process of innovating and redesigning social care are absolutely caught up in trying to manage situations such as that I described in my report in Moss Park, and the other care homes that we know that we could name in just very recent weeks and months have also struggled or indeed closed and have needed an enormous amount of input and attention. So one of the factors that was recognised is that we probably need very early conversations about how we can utilise some of that transformation money to bring in maybe some additional staff or support to help us to create the planning for the change, and not just to expect that from our existing. I think it was one of Pam's phrases about flying the plane and changing the plane. Maybe can't quite remember. Pam said it better than I ever did. But we're going to need to support our social care and integrated leadership team to be able to make the change. So Derek and I are very keen that we should pull our teams together in the next couple of weeks so that we can really work together on what that transformation is going to be and how we're going to make sure we can use the money to its full benefit for the partnership.
Thank you, Fiona. Okay, I've got Jerry next, please.
Thank you, Sarah. Probably on a completely different topic, and it's probably not maybe a question specifically for Helly. I did well, two questions actually. I did notice in I think it was the comms update that came round that the Argyll and Bute IJB are projecting a considerably higher figure than we've got in our finance report. But I think I take that in the context of we're going to be revising as we move forward, so really not going to dwell on that. I suppose my real question or observation was I was reading the finance report, and again, it's the more you get, the more and reading the health and care staffing report that Gareth has got later on the agenda. And I think one of the issues that I took from the health and care staffing report, I'm trying to think of the best word the way to describe those, was the state of disrepair of our e-rostering process. And it does lead me greatly to question whether without an effective e-rostering system, how much hope we've actually got of significantly reducing our supplementary staffing bill, other than be using the very blunt instrument of stop, which is not where we want to go at all. And I think I did know, I did pick up as well in the spreadsheet that was appended to Gareth's report that the vast majority of where we've reached 150% limit is caused by travel and accommodation, which is not very surprising. And I think, apologies if I've picked this up incorrectly, I think we're probably looking to stop that going forward, which you would imagine will have a quite dramatic effect on levels of spend. But it was more that. So it's probably more an observation. I was actually quite surprised that I said, well, how do we think we can actually effectively reduce our supplementary staffing bill if we don't have an effective e-rostering system in place? Thank you.
I'll come in on that one if
Yeah,
that's okay.
Gareth,
Yeah. So we are taking advantage of pausing rollout of Health Roster to use the resource we have available to do a rebuild of the rostering system. And that is, we've got a draft plan to do that over a 15-month period for the 160 areas we've rolled it out to. However, we might be able to shorten that still further. So initial work in one pilot area is demonstrating quite significant improvements in that space. So you're right, it is an area we need to focus on. Yeah, so it's good we've identified an action to take forwards. And it's being embraced positively as well by our nursing colleagues, so that's good. The secondary bit is probably just to provide assurance that the two, I suppose the two main, well, three drivers probably for supplementary staffing are partly extra activity, where we've got above what we're funded for, so beds that are open where they shouldn't be potentially, or we're having to keep open and staff. So that's an example. And the other aspect is vacancies, where we do have vacancies against a funded establishment. And the third element is probably efficiency and effectiveness of using supplementary staffing. So a focus on reducing agency. We have made significant progress in that nursing towards bank and consistently using bank. So there's been significant work done to recruit, and that's helped in acute and in mental health, including international recruitment's been part of that solution. So that's one part of it that's provided some improvements. And reducing agency has continued to make progress as well. So that's just to give assurance back to the board that we are seeing some improvements. But there's still always more work to be done. And the next part of our focus, I think, again, we've referred to is a concentrated piece of work looking at delayed discharges in our acute system and how we can impact on that. So again, that will be a real impact on our supplementary staffing going forwards from a nursing perspective. Medical locums is probably our more challenging area in that we're probably as efficient, as effective as we possibly can be in terms of direct engagement. 100% of the agency that we engage through the bank are direct engagement, which minimises our costs. However, the key issue here is to ensure we look towards replacing locums with substantive appointments, which is not necessarily easy given the employment prospects or the labour market, should I say. So I'll stop there because there's quite a lot, just to give you a flavour of the fact there's quite a lot of work ongoing in and around that space. I think that was everything.
Thanks. And I can see that Louise wants to come in as well. So Louise, I'll bring you in.
Yeah, thank you. And apologies, I'm sounding a bit croaky today, but in terms of nursing, there is an expectation nationally that we use agency by exception only by the end of October. So there is a real drive on to get us to that position, and certainly the trajectories are going in the right direction, albeit it is a challenge. I think it's also worth just referencing as a board, we do have a different position because of our care home situation. We have quite a lot of agency use in some of our care homes, which would be less evident in other boards. So we've got that factor. We've also negotiated with Scottish Government that because we're doing some additionality in terms of planned care, that we will use agency for that, because recruiting to that would have been really tricky for such a short period of time. So there are nuances to all of our supplementary staffing use that we have to identify and articulate both locally and nationally, because it's not simply let's reduce everything. There are pockets where there's particular challenge and particular vulnerabilities.
Thanks, Louise. And Boyd, please, I'll bring you in.
Thanks, Chair. I think Anne had a hand up before me, but I was just going to come in on the medical workforce, and Anne maybe on a different thing. Just in line with what Gareth and also what Louise said, the medical workforce, particularly the use of locums, is a challenge, but it's a balance because we have services that we want to supply and have in the Highlands, or have always had. The problem is that the medical recruitment market is a difficult one, and recruitment here can have issues, and so sometimes we're not able to not have the locum, if you forgive the double negative. We have to have it in our current setup, and some of these services now are locum dependent, and we probably have to think about how we manage that going forward, where that becomes a chronic problem, because locums are not always available either. So it's not just a financial lens, but there's a service lens, and the what can we do locally versus what does NHS Scotland need to step up and help with.
Yeah, thanks, Boyd. That's very helpful. Okay, and Anne, I'll bring you in, please.
So I would like to just go back to some further clarification around the process for drawing down any of the very welcome reserves that the council have offered for transformation projects, which Aleth was talking about. And I just wondered whether anybody can say how the business cases that might come forward will be judged, and what the context will be for agreeing that the projects are transformative, if you like, in the context of our services. Thanks.
Thanks, Anne. I don't know who's going to pick that one up. Heleth?
I'll start, but maybe Pam will have some additional information to share. But I haven't seen a scoring matrix or anything at the moment. Not to say that hasn't been pulled together, but the intent behind it is obviously around increasing capacity, reducing costs, improving quality. So I don't think there is a direct scoring methodology, but we can certainly pick that up with the council and have a look at whether we should have something a bit more formal in place. But it's all been driven through the portfolio board, which I'm not a part of, so I haven't seen that detail, but we can possibly bring that back.
I wonder if, sorry, Alistair, I know you popped your hand up, but I wonder if Fiona, I'll bring you in just off the back of what Heleth was saying there.
Yes, again, I'm not close to the details, so I can't give you a description of any scoring matrix, but Derek was clear in our conversation that anything that supports the implementation of the joint strategic plan and the stated aims within that will be within the scope of consideration for that funding. But again, Pam may be closer to that because she's a part of the board itself.
Thanks, Fiona. Alistair, I'll bring you in because I'm assuming your question is all linked in with this, and then Pam can sort of wrap up for us. Alistair?
Yeah, thanks, and thanks for Anne for raising that additional question. I suppose if it was a true partnership, we'd probably know the answers to some of these questions around scoring and around evaluation and what the role of the JMC. One would assume the JMC would be the final decision maker as a joint monitoring committee overseeing the lead agency model on whether something actually meets the requirements to be treated as a transformation scheme and to go ahead. I suppose my concern is the 20 million is over 3 years, yet the 7 million is coming off in year one, Hellas, which means that if there is not the phasing of the 20 million in line with that, then NHS will be carrying that potential teaming and lading risk to the 7 million over the period. And as you know, as you said, we can't take the 20 million because we're annual accounting. So we could actually be making our brokerage position worse, depending on how we financially handle the 7 million reduction and the 20 million drawdown. But I think to me, there's a lot of unknown questions around the process for the 20 million drawdown. Is it the case that the JMC is involved in this or not? If it's not involved, then I suppose I've wondered for a long time what its purpose is, but if it's not involved, then I think that weakens its purpose even more as the Joint Monitoring Committee overseeing the lead agency model and the monitoring and the finances of it. Thank you.
Thanks, Alistair. I'll bring Pam in and then we'll maybe touch a little bit on the JMC there as well. But Pam, I'll hand over to you now.
Thanks. Just in terms of some of the projects, so against the 20 million, they have to be transformative, and we have to demonstrate through that business case the outcomes or improvements for people or in service. Some of the projects that we've been looking at, and some of them we've been identifying as part of our urgent and unscheduled care work stream in terms of our system capacity and how we can improve, for example, technology interventions to enable people to stay at home. So we've started to scope out some of that at the moment. The other frame is that the 20 million transformation fund is a 3-year fund, so we're not expected to articulate projects and spend them very quickly. There's going to be some short, medium and longer term projects that we need to identify. We have already had some projects identified by the Highland Council themselves in terms of project management to support us in some of our transformation. So we're just looking at matching that up at the moment in terms of what we need to do.
Thanks, Pam. And just to pick up, Alistair, I think your questions and your points there around the role of the JMC are well made. And whilst they haven't been articulated in exactly the way that you've just framed them, I think your questions are reflective of conversations we've had within the JMC and within that partnership development space of the JMC. So I'm happy, obviously, myself and a number of others sitting around this table attend the JMC, and we can certainly bring that into the conversation. But you're right, there's a fun, we need to from time to time go back to basics and consider the role and the function of each committee and whether we're fulfilling that. And we have begun those conversations, but you're right, there is more to be done there. So I'm happy that myself and others can take that into the JMC development space on your behalf, and we can pick that up through that. And of course, do that in the partnership because it is a partnership space. It's not just our space. So it's important that we do that with the others that sit around the table. The Highland Council, of course, but other stakeholder members too that are part of that structure. Okay, I'm not seeing any other hands up there. So just to recap, the assurance level that's being proposed to us around the finance update is limited. So we were asked to examine and consider the implications of the report and take that level of assurance. We're happy we've done that. Great. Okay, so that takes us on to item number 6. I'll invite Pam to speak to this one. So this is our update on the urgent and unscheduled care plan, which in brackets, delayed discharge mission, which Fiona touched on in her report earlier on. So Pam, I will hand over to you, please.
Thank you. So this paper is a briefing for the board, and it's for noting. And as Sarah just mentioned, this is to outline our response to the First Minister's mission. Then he commenced a mission to reduce people in delay by the end of October. He commenced that in the summer, and has brought together a number of systems to enable us to work at pace. There's weekly oversight. There's a weekly oversight group chaired by the Cabinet Secretary and attended by COSLA and all of the chief officers. So a very deep dive into people in delay and what our numbers look like across Scotland in every integration system, and also an opportunity to look at where there has been progress made and what we can collectively learn from that and apply to our own systems. So the First Minister has stated that he requires a maximum of 34.6 people per 100,000 of the population, baseline to be achieved by the end of October, and specifically ahead of winter pressures. That's really challenging for us in Highland. So in terms of the workforce issues that have been well framed, throughout our discussions today, and also the capacity issues and the system capacity aspects that Fiona mentioned earlier in her chief executive report. Nevertheless, the 65% is challenging for us. What we've looked at in terms of what we think we can deliver and what we've measured to try and deliver is a 30% reduction, and we're working on that. So we've taken an overall look at our urgent and unscheduled care programme. We've refreshed our governance and system reporting so that we can align all of the system dashboards and reporting and data in a way that's much better understood. And we've stood up a 90-day improvement plan. So the overall governance of the programme is that we now have specific acute and health and social care programmes for urgent and unscheduled care delivery. They also deliver on interface pieces of work, for example, frailty. We also have those groups reporting into a steering group fortnightly, which I chair, where we go through a very focused action plan with our senior responsible officers and our professional leads to take assurance around the progress that's been made, and not only take the assurance but seek the evidence so that we can see the standard operating procedures and then put plans in place to make sure that we're delivering on them and measuring against implementation and progressing that through our action plans. So I also provide fortnightly assurance on the progress against those work streams to the Executive Directors Group, and also engaged in that assurance then, or alongside me in the steering group, is the Chief Social Work Officer from the Highland Council, so that we're working in partnership to understand our whole system. A key piece of our new governance refreshed approach then is a system capacity and an operational action group. So our operational action group meets daily. 3 very senior system leaders across our acute hospitals, our rural general hospitals and our community services. Very senior system leaders meeting daily, making sure that the district management teams are operating, that they're following standard work, that there's daily delayed discharge management, and all of our systems are stood up and operating. And alongside that is a group that is looking at system capacity, and Catherine Sutton's been leading on that group, looking at some very intensive work and outputs around our system capacity in a very challenging area, where you'll see in the paper, we've got approximately 70 people waiting for a care home at the moment, and you know we have less and reducing capacity going forward. But one of the things that we need to do in terms of our system capacity is then, you know, understand our baseline data. It's quite complex to understand our data in terms of care homes because they're operated by different systems. You know, we've got independent sector who are partners and who we may have no control over, or who could make decisions about, you know, the people that they need to accept, or the way that they are paid, you know, whether they want private paying people or whether they're willing to work with a national care home contract. What we're seeing more and more is that people have very complex needs and require extra staffing. So all of those considerations make it difficult to understand the capacity that we actually have and the live capacity that we have in care homes. So we are working very hard in that space to try and align all of that so that we can be very clear about where our capacity is available. We're also looking at our community hospitals and making sure that we're using our community hospitals at maximum occupancy. And as we move people through the system into care homes and community hospitals, we should see that closure of the acute beds that have been stood up and the financial impact of that reduction in terms of people being cared for in the right place, as well as the quality aspects in terms of people's care. We're also looking at introducing EHP at the front door, so that would be an example of where we might look for transformation and where that might help other elements of our system. You know, if we understood our capacity, then we would maybe be more dynamic around managing people who present at the front door and getting them home quickly or return to where they need to be and prevent them having a long wait in accident and emergency, for example, and then sometimes ending up in hospital. And then we've got quite a lot of work to do around our future priorities. So really having that capacity plan, but really being able to see what that capacity plan looks like daily. What we've done as well is we've set targets, you know, for the 30% reduction, and we have articulated them to the districts so that we can see where we need to focus our effort in terms of managing our capacity, standing up some capacity that we need to open up and use in terms of moving people through the system. And in parallel to that, you know, really dynamic recruitment, trying to make sure that we recruit to the placements that we need in care homes, but also wider recruitment across our partnership and collaboration with our partners. So recruitment for the independent sector is just as important, and also looking at recruitment for personal assistants to deliver self-directed support. So really opening up and standing up all of our capacity in all of the areas where people require care and where they have got a need for care. We saw in the IPQR earlier about our delayed discharge, the average performance sitting at 195, and the reported performance for that report at 207. Nationally, in more recent data shows us sitting at just under 200. We have made some progress. We did have some challenges just at the end of the summer there, or during July and August, with hospital-acquired or infection, COVID infection, and other infections in hospitals, which meant people stayed a bit longer in terms of their length of stay. So we've managed to have some early evidence of our improvement, but not enough to bring that forth and say that that's sustainable. We're halfway through our 90-day programme that we stood up in August, and a lot of that time has been about the system capacity priorities, making sure that people are delivering on the standard work and measuring that every day to make sure that our systems are optimised. And we've been very focused on getting that right at the start, so that our 90-day programme is set up for success. So in the appendices then, we have our some of the urgent and unscheduled care trajectories that we are working to, and we've got some some numerical performance around that. And then the second appendix shows in detail our 90-day action plan, the plan that we're in the middle of improvement across a number of areas in terms of responding quickly to our population when they enter our service, to make sure that we manage them quickly through the touch points at the front door. That rapid discharge, making sure that we've got all of the systems and all of the bundles around discharge without delay operating. So within that operational action group that's happening every day with our senior system leaders, then really testing that and really testing the system to make sure that it's working at optimum where we are using our discharge systems, and that our operational pressures are managed and don't become problematic. Also in terms of reducing occupancy, so the whole big capacity piece around the people in the right place at the right time going forward. So the report is there. It offers limited assurance because we're not really reporting out any of the specific data that the board would need to see at this stage. As I said, we've set up the programme. We've done a lot of work to get it into the right place and get the governance systems, reported and stood up. And we are providing assurance internally within the organisation, and also weekly through the national group that's set up and chaired by the Cabinet Secretary. So I'll stop there and take any questions. And also Catherine's on the call as well, who's done a lot of work around the system capacity, so either of us can take the questions. Thank you.
That's great. Thank you, Pam. Okay, I'm going to open up for questions, comments. I've got a couple as well, which I might throw out in a minute. Alistair, I'll bring you in first, please.
Yeah, thanks. I think there's a lot of good work going on, Pam, around the governance of this and the accountability and making sure there's a good process. However, I think the issue to me on this, that I'm pretty sure I read somewhere that it was recently 400 people waiting to be assessed for care, packages of care, and that there is about 2,500 of unmet care at home need, which equates to about 70 people, a full-time equivalent. So I don't see how we can turn this tanker, because obviously we're not attracting people into the profession, and especially care at home, with other care homes closing, and the problem we're hearing with the Fort William one, and the level of funding for the National Care Home contract. So I think with the lack of vacancies, the care home contract, the 400 people waiting for assessment packages, that it's almost like a perfect storm on demographics and resource coming together that's going to make it very difficult to actually address. And I suppose on these numbers, and it's very difficult when they talk about national maximum level of delayed discharges, but Highland must be a real outlier in terms of the number that we have of just under 200 compared to other areas. That I worry on this. And the only solution to addressing this is to make sure that it is an attractive career for people, in which case the salary will have to go up, that it is higher than working in one of the restaurants in the city centre or one of the tourist outlets, because to me it looks like it's a salary driven project. If we don't pay the right level for the care at home and the responsibility for staff doing the care at home, then we're not going to address the delayed discharge situation in a quick and meaningful way.
Thanks, Alistair. Fiona, you popped your hand up there. Did you want to come in on that?
Yes, I did. Thank you, Sarah. Pam, thank you for taking everybody through that. And I think, Alistair, you've made some really thoughtful and pertinent points there. I think for me, what we're trying to brief the board about today is that within the existing context, that we're not leaving any stones unturned in trying to resolve this issue for the people of Highland. And I don't think Pam said anything about it being quick. I think we all know that it's not going to be quick. But we are also aware, as I mentioned in my Moss Park comments earlier, that we operate in a policy and regulatory context that is not of our making. But we do all have voices within our pertinent networks and conversations where we have opportunities to try and influence regulators, policymakers, to understand the impact, and I'm sure many of them are unintended impacts, of decisions that have been made within the inspection space or the regulatory space or the policy space, and how they converge in our area to create a particular outcome and are additional challenges for us to meet the needs of our population. So I certainly can assure you that I miss no opportunity, as Sarah and others can attest to, when I have an opportunity to influence decision makers, to talk them through those impacts and to give them tangible examples. And for me, Moss Park is one of those, but there are many others, to try and help them to see what they could do to assist us. And I suspect as board members, you all are part of networks and have opportunities to influence too. But I think as executives of this board, we have to demonstrate that within the constraints and parameters that exist for us, we are doing everything that we can to shift this problem for our population and for our staff, as it's been mentioned in staff governance and other areas. People within our acute systems are really feeling the pressure. People that manage our community services worry about that unmet need of people who are at home. And we have to demonstrate that we are doing everything that we can to move this situation forward, being if you like, optimistic in the face of what would be easier to be pessimistic about.
Thanks, Fiona. And Pam, did you want to come in as well on that?
Yes, I did, thanks, because clearly working across the sector and collaborating on a number of issues, especially around workforce, where I mentioned earlier we've all got challenges. I want to just outline some very dynamic work that we've undertaken as part of the collaborative work we've done with our care home sector in Highland. We, through the collaborative monies, we have, in partnership with Scottish Care, appointed an independent sector career and attraction lead. Now, I don't know if any of you have been on social media, but you may have seen some of the vlogs that some of the staff have been presenting just around their experience of working in care, about promoting the different careers within care home setting, and to give a real live experience, from all sorts of different people all over Highland about their jobs. We've done a lot of engagement. There's a map being produced that's really interactive. So we've had 5,200 hits to that map for people looking at the care homes and the jobs, etc., since the 8th of May. We've got much more robust engagement with secondary school careers events, outreach into schools and into the college, and also there have been in-person visits to 24 of the care homes so far by the independent sector lead, just to make sure that we've got that engagement right, that we can co-produce solutions to workforce and work actively in that area. So the collaboration is really important. It takes time, but it's been stood up and it's in place, and we're really beginning to see some good progress and some good metrics around what's been achieved. Just during the last 4 weeks, we've had 247 young people engaged in careers events, from school careers and specific workshops that have been set up. So all really encouraging, and I think the use of social media to engage people has been really dynamic, and we're beginning to see the outcomes. It's going to take a long time to turn this around. What we have done is we've built a robust framework. We've got our 90-day plan. We've got our governance system in place. We're really looking at our capacity, but we won't achieve that just on our own. The collaboration piece is really, really important to us for our collective achievement across all of our sectors. Thank you.
Thank you, Pam. That's helpful to understand some of that detail. I have seen a few of the blogs. They're very good, actually. Okay, I've got some other people waiting to come in. I've got Anne next and then Karen.
Thanks, Sarah. Thanks, Pam, for the report. I've got a clarification of some detail that it would be useful to have, but then I want to make a broader question. So just on the detail, I wondered if you're able to either just now or in the next report that we receive about progress, just clarify some of the numbers. So we're expressing our own target as a 30% reduction in our standard delays. And then we have the government target, which is expressed in a very different way. So I think it would be useful to clarify how many people 30% of our standard delays represents, so we can get some context in relation to, for example, the extra capacity that we're hoping to achieve in care homes, but also to understand how our target relates to the government target. So I understand you might not be able to do that straight away, but I think that would be useful in any future reports. But I suppose my broader question is really the report usefully sort of sets out some of the issues that we know pertain particularly for our rural board about additional costs or the additional challenges that we face in terms of capacity for social care. And I just wondered if we knew, is our additional capacity that we are having to try and generate to address this national mission going to represent an additional financial risk for the board, or is there any prospect of additional support from the government to meet the costs of the additional capacity that we're trying to create? Thanks.
So on that, we decided on the 30% because we know that that's 65 people. We have identified some capacity that we need to stand up within our existing care home sector, so our in-house care home sector. So that's a piece of work that we've been leading on. Clearly, we've not been able to operate at full occupancy those services due to significant workforce challenges. So the Cabinet Secretary has asked us what it would take to open up those beds in terms of additional staffing that we may need. I referred earlier to elements of complexity and people needing to be, the staffing model needing to reflect that, where people might need 2-to-1 support, for example. So we're seeing a lot more complexity across our system, and of course maybe there's challenges for the independent sector to take people with complexity that I mentioned earlier on. So it would be 65 people. We currently have just short of 70 people waiting for a care home. So we're hoping to achieve that and work at pace in the next few weeks to try and get that capacity opened up. And that's where our focus is in the system capacity group at the moment. Thank you.
Sorry, did you want to come back in, Anne?
Well, I just wondered if Heleth might want to comment on whether, I mean, it's good that the Scottish Government have asked the question, but does that mean that, if we don't get additional resources, this will be an additional pressure within the overall financial picture? And
Yeah, Celeste, on you go.
Thank you. We need to do that financial evaluation to see what the wider plan is and to bring it all together. The intention would be that at the very worst, you'd be shifting costs, so we'd be taking capacity out of one part of the system to put it into another. But there is that conversation to have with Scottish Government. So there's lots of pieces of the picture that need to come together before we can take that decision or assessment. So the intention wouldn't necessarily be to increase the cost across the system. It would be to deliver care in the right place.
Okay, thanks, Celeste. And sorry, my brain's spinning with the information. Karen, I'll bring you in next, please.
Thank you. I feel a bit the same, Sarah. Thank you, Pam. And I probably should have asked this when we went through this last week, or was it last week? Does this cover Argyll and Bute as well? I can see on page 174 that Argyll and Bute are referenced and their percentages, but I just wanted to check, and if not, is there something perhaps for Evan, is it something that we will see replicated across in our IGB work? Really just from my understanding, sometimes I get a little confused about the reports and whether they cover Highland Health and Social Care Partnership only, or whether they cover Argyll and Bute, or whether they cover both, if you see what I mean. Thank you.
So both partnerships have an urgent and unscheduled care programme. This report to the board today is specifically in relation to the Highland Partnership area. So the data that we're referring to refers to that. In terms of, oh, sorry.
Thank you. And therefore, would it be helpful for us, or is it something, Evan, that we can pick up in our IGB at some point? Would that be useful? I just feel it would be nice to see a comparison.
Absolutely. And I'm maybe take it offline with you, Karen, and we can think through maybe an IGB development session around this as well to make sure that we're fully kind of understanding our system as regards unscheduled care.
Thanks, Evan. And there's always a bit of it does always feel a bit lopsided, Karen, doesn't it? Because, and I remember when I was chairing the IJB, there's the kind of there are different layers of scrutiny and governance that sit in the IJB that we don't necessarily have in the Highland Council area. So it feels a bit lopsided, but you're right, there's something about bringing it all together. And perhaps if you and Evan take that offline through the IJB, but we can think kind of into the future, how we maybe pull that in so that we get a board-wide view of it, taking into account that lopsidedness that we do have, but we can try and pull something together so we get that whole picture as a board, as well as a kind of the recognising the two integration models. Yeah, on you go, Karen.
Yeah, thank you. I was just also, for my just a point maybe that Evan and I will pick up is if there is some funding available, just to make sure that we've got our share of that as well.
Absolutely. Okay. Sorry, Evan, you wanted to come back in yet?
Yeah, just to kind of respond to the specific issue raised, I can give assurance that that kind of engagement around the funding and the split and how those plans dovetail is happening at an NHS Highland level, and we're involved in that. So thanks for raising that, Karen.
Perfect. Okay, I'm not seeing any other hands up, and I did have some questions, but they've pretty much been picked up by others in their comments, which is handy. So we are being asked to note the content of that report and take limited assurance at this time. So members, I'm assuming, are happy to do that. Okay, we're slightly ahead of schedule. I'm just going to suggest that we take the National Care Service response. I mean, we've got it on, I don't think it'll take us too long, so I'm going to suggest that we do that and then we'll break for lunch if everyone's okay with that. Great. So Gareth, I will hand over to you. We're obviously all familiar with this because we've been involved in it, but Gareth is going to update us on our response to the National Care Service consultation. So over to you, Gareth.
Yeah, I'll keep this very brief. I'll take the paper as read, as we've had 2 development sessions with the board looking at this, the stage 2 amendment, stage 2 bill amendments, and our responses to that through the public consultation. This is for completeness to bring to the board the summary of the response sent back through the online portal for the public consultation. Probably just to note that there has been a combined excuse me, a combined response from the NHS chairs and chief execs in relation to this consultation as well, which mirrors in many places our responses, although obviously NHS Highland has focused on the lead agency model specifically in the context of being the only organisation in partnership with Highland that's taken that model forwards. So it's really here just for noting that we've submitted the consultation response, and we'll see what comes from this in terms of which amendments go forwards. But we are aware there's a number of ongoing conversations, including between COSLA and Scottish Government, and obviously through other stakeholder forums as well. So we'll wait and see what happens.
Thank you, Gareth. And as you said, we've obviously looked at this a lot through our development works. And I would just like to say, actually, that I think the way we've done that has been recognised as good practice for kind of gathering the views. I think one of the things I've picked up from speaking to my counterparts in other areas has been the difficulty in gathering those views, not least of which because there's still a lot of detail that is yet to be determined. So it's quite difficult for people to respond, particularly the way the consultation was set out with that strongly agree, disagree, but when there's some detail missing, it's hard because obviously we're all processing that through our own biases, which leads to a variety of answers. But I think the way that we captured our collective feedback through those development sessions and added in that level of narrative has been really, really helpful and good practice. So I'd just like to say thank you to yourself and the team for facilitating that. I know it's not easy to gather the views of a wide range of people on a slightly fuzzy topic and pull that into something as a cohesive response. So that's good. Jerry, I'll bring you in, please. You've got your hand up there.
Just very quickly, Sarah, would it be possible if we've got it to get a copy of the combined chairs, chief executives response, just so we can read it and compare, contrast, whatever?
Yeah, I'm sure we can do that. Fiona?
It's publicly available on the parliamentary website, but we can share the link with the board.
Excellent, thank you. Okay, Susan, I'll bring you in, please.
Just a quick point. I agree. It's done a really good summary, pulled that together very well and given us lots of information that we need as a board. So therefore, I'm still bemused that it gives us no assurance. The assurance level is still none on this paper. Thank you.
Do you want to come in on that, Gareth?
I suppose, what are we providing assurance around? It's awareness that we've submitted it, we've gone through. I'm happy to revisit it, but I'm just thoughtful it's a summary of our views. So
it's tricky as well, isn't it? Because I suppose, yeah, I think I know what you mean, Susan. It's sort of assurance that we've gone through a good process. It's maybe a little bit tricky because well, I would consider that we've gone through a really good process, and it would seem that way when I've sort of listened to other people's experience. There wasn't ever a kind of a benchmark or a guideline of to how we should do that. So we might, I suppose, commend ourselves on how we've done it, but it is a little bit difficult because there wasn't really a standard. But I think you're right. I think we can record that as a board we feel that was a good and robust process that we went through, resulting in a good solid response, and I'm happy that we can record this. I'm not sure, it's tricky, isn't it? But I think it's a point well made, and absolutely hats off to the team that did that for sure.
Yes. I wouldn't want to underplay us, but maybe it's something that's not applicable as an insurance level or something, but it's clear that we have gone through a good process and we should have it noted, the work that's gone into it, rather than say, well, we haven't done anything.
Yeah, no, I think that's a good point. I think we can reflect that in the minutes, actually. Yeah. Fiona?
Yeah, I just wanted to welcome that from Susan, and maybe just to specifically draw out Gareth's contribution to supporting me with that, because as colleagues will know, I've been very involved in that national response as one of the two board chief executives as part of the National Chief Exec and Chairs group. So it's been very useful that Gareth's been taking the weight of our board process and ensuring that those voices have been fully contributing in the response. So thanks from me too. And Susan, thank you for making sure we give ourselves credit where it's due.
Yes, we need to take it where we can. Thank you. Okay, everybody, not seeing any other questions. We'll get that the other response circulated, Jerry. I think that's a good shout. Great, right. It is time for a lunch break, and I will see you back here in half an hour at 1 o'clock, please.